Thank you, Chairperson, and it's lovely to be here. Thank you, Dr. Manoj, Dr. Purvi, and the entire team of DRS. And again, once again, reiterating, hopefully you're absolutely clear about what our debate is all about. My dear colleague just convinced you that you can, treat all diabetes with weight management. How many of you agree with that? Please raise your hands, and then I'll try to convince you otherwise. I wish life was as simple as that. This is the number that you have. This is from the ICMR India. Can we have our slides, please? Perfect. So more than 100 million people with diabetes in India. This is from the ICMR India study. Nearly 40% of the Indian type 2 diabetes have BMI less than 25. Forget it. We have a different cutoff, and you can debate that for us, the normal BMI should be less than 23, and that's 20 to 25% of the people with diabetes. These are lean diabetes. Weight alone doesn't explain or predict the diabetes burden. It's oversimplified when you say you can only manage diabetes with management of weight, because we have diabetes clusters. And if you look at the clusters, there are certain places where weight management fits in. There are other places where it doesn't. Let alone type 1 diabetes, where treatment is only insulin. Even those who are falling in the cluster which belongs to severe insulin deficiency, that's about 25%. And then again, MARD, that is another 30 to 35%. Almost 60% of your patients do not warrant diabetes management based on weight. So severe insulin deficient diabetes, weight loss is not relevant. Mild age-related diabetes, weight loss therapies offer little incremental benefits, so almost 60% is gone. Type 1 diabetes, non-obese variety, again, require insulin. So a significant fraction of your diabetes cannot be managed with weight as the main focus. Now, you can debate that we have now molecules which not only target the weight, but it also gives you organ protection. So let's look at the major data coming in and the kind of weight loss you had from various trials. Say for the major cardiovascular outcome trials that has been done with the GLP-1 receptor analogs and SGLT2 inhibitors, you see the magnitude of weight loss that has been there on your right-hand side. And I'm sure my colleague has convinced you that if you want remission of diabetes, you want a weight loss of 10 to 15%. And look at the kind of magnitude of weight loss that you had in terms of cardiovascular protection. It's only 2 to 3 kilos. So obviously, weight is not the central part in cardiovascular safety. What about the renal outcome trials? Again, very interesting. Look at the magnitude of weight loss that has come in with the SGLT2 and GLP-1 based therapies in various renal outcome trials. So obviously, to protect the kidneys, you don't want a major weight change at all. So it's the molecule that is actually benefiting you, and it's not the weight loss at large. What about the heart failure trials? Again, the magnitude of weight loss that you can see it in yellow, highlighted in yellow, and it's very minimal. So, the kind of weight loss that we are talking about, 7 to 10% was not there in any of these trials. So this is unpublished data, and I've written a short disclaimer there. This actually compares all the trials, cardiovascular outcome trials, heart failure trials, and I've gone in depth and analyze those who are having diabetes in this cohort. So many of these would have both cohorts would have diabetes and without diabetes, like the renal outcome trials as well as the heart failure trials. And if you delve into the population who had diabetes, the magnitude of weight loss was less than 5% in majority of the trials. Now you see the top two, very recently, you had the terzepatide surplus CVOT, which showed there was a weight reduction, significant weight reduction, as well as the MSLD study, like the ASCEND study with the higher doses of semaglutide, which showed some amount of weight loss. But let's delve a little deeper in this. So the ASCEND trial that came out with semaglutide 2.4, the mean BMI at baseline was 34.6 kilos. And only 33% of the Indian type 2 diabetes has a BMI of more than 25. So obviously it's not very relevant to our population. The BMI profile of the Indian type 2 diabetes differs significantly from the global obesity-driven cohorts like Essence, and weight loss-centric therapies may not directly map onto the majority of the Indian type 2 diabetes. So this is a summary of the Essence and the Indian cohort which was recruited, and obviously you see it doesn't fit into our cohort at all. This is a STRIDE study with semaglutide. Again, the weight benefits were not looked into because it was only with 1 mg of semaglutide, and obviously it's the molecule that is helping you and not the weight loss. So the closing statement is, in India, diabetes is not just a disease of obesity. Lean and sarcopenic diabetes is common. Complications and outcomes are driven by glycemia, comorbidities and heterogeneity, precision medicine. So one shoe doesn't fit all. I'm sure I'm going to ask my colleague to wear my shoes after this talk, and I'll try wearing hers, and I'm sure I'm not going to fit in, and neither will she. So I think we need an individualized, customized approach, and just targeting obesity is not going to do the job for us. We need to have an individualized, customized plan for all at large. So thank you so much, and hope I've been able to convince you. Thank you.
Thank you, Dr. Bhattacharya. So if anybody has any questions, both the doctors are here. Dr. Lakshmi is also here to answer your questions. Anybody from the audience? So you can use the mic there.
My name is K.R. Dhebri. I practice general practice in Mumbai from last 46 years. Occasionally, we come across people who have suddenly lost about 10 kilo weight. And then we know that this could be diabetes. And sometimes the relatives tell us, So how do you explain this? How do you explain that? Because we are talking about obesity and diabetes and weight loss. So how do you explain that a person who has lost 10 kilos, then we diagnose these guys as diabetics?
So if you see that a person is losing weight, that means he's probably insulinopenic. It's a catabolic state, and that is an emergency, and you need to treat only with insulin. So weight loss that's exactly what we were talking about. So there's a cohort of patients, the variety we call SID, possibly, or adult onset type 1 diabetes, which we call LADA. Many of these would warrant insulin to begin with. So in this particular cohort of patients, weight loss is not the approach forward to treat diabetes.
No. What I am asking you is, how do you explain this sudden weight loss over a couple of weeks from 8 to 10 kilos, and then these guys are generally diagnosed as diabetes? How do you explain the weight loss?
Yes, sir. Like Dr. Supratik said, it's the catabolic features of newly diagnosed diabetes because of the insulin deficiency that can lead to weight loss. The glycosuria, polyuria, polydipsia, and weight loss are classical catabolic features of newly diagnosed diabetes, especially when it's uncontrolled and very high at diagnosis.
Thank you, Dr. Lakshmi and Dr. Supratik, for the very lovely talk.
So conventionally, you have a raise of hands to see how many are convinced after the talk.
No, I think nobody can agree with both of you. The first, of course, a person coming, we all know the first advice, obese person, diabetic coming, weight loss is the first advice, and lifestyle management is the first advice we give. So she is right. You are right saying that, yes, it is not the only way out. It is a multifocal, and each the patient is individual. So both of you are right.
Fantastic. Thank you. I think at the end, science wins, and congratulations.
So, congratulations to both of you. Just a small comment. Dr. Supratik, I can challenge you here, standing here. You can't manage a day in her shoes. We women will manage in your shoes.
Agreed.
So, moving beyond that, sir is very right. You can't generalize. Obese population with diabetes has an answer in obesity. But non-obese population with diabetes, the different cohort, definitely we won't be targeting obesity there. So the debate or the topic of discussion is that obese population with diabetes, the primary target has to be obesity, but non-obese population with type 2 DM, of course, obesity can't be the target. So both of you are right in your perspective. The cohorts itself are different.
Exactly. So the debate was about weight management should be central to diabetes management at large. So obese word didn't come. So
Yeah.
no. Can we have the topic? Can we have the topic posted
correct,
here?
correct. In that, but 88% of people with diabetes do have obesity, or
I
the
agree.
other 12% do have thin fat obesity. Yeah.
So I think the conclusion should be the weight management should be the primary focus. Whether it is lean, it should be good muscle mass, and when it is obese, it has to be good BMI.
Agree, undoubtedly.
You have an ardent fan with you, so she's already charmed.
So like I said, I was presenting from his slides. I don't know if anybody here was at Bangalore 3 months back, and he was presenting the same slides. So, it's a win-win for him. It's his slides that I was presenting from. So that's a disclaimer.
Thank you. That's so kind of you. Thank you once again, everyone. Thank you, Chetan.